Thanks, John. Appreciate the invite again from BASEM. I was here about 2 years ago and spoke about patellar tendinopathy. So today I thought I'd talk about the state of play of tendinopathy at the moment. So it's not looking good, really, for tendinopathy. We know very little of this complex pathophysiological process, and I'm going to outline some of the concepts and some of the principles of how we manage the tendinopathy now, and then talk about some of the emerging concepts. And in fact, I'm going to talk mostly about rehab, so don't leave the room just because I said that, but talk about rehab and some of the emerging concepts of rehab that we're using to try and optimise our management of tendinopathy. This is a really difficult problem. I've worked in tendinopathy field for about 10 years, and I struggle sometimes with patients. They're very difficult, and if they're elite patients, it makes it even more difficult because you've got a time pressure to get these patients back, which means that, certainly as a sports physician, you often resort to dubious and potentially harmful interventions that actually set the athlete back rather than forwards. So also part of this talk, I'm going to mention four standout papers from the last 3 years. Anyone who deals with tendinopathy, I would advise you to read these papers and come to your conclusions about the principles in these papers. So tendinopathy is an absolute epidemic. 1 in 10 of patients will suffer, or 10 in the population will suffer from tendinopathy. And it's actually more common than osteoarthritis. This is a Dutch study done a few years ago that found that patients presenting to a general practice, more patients in that practice had tendinopathy or diagnosed with tendinopathy than in fact were diagnosed with osteoarthritis. There's 4.5 million visits to physicians in the US each year, 4.5 million. And the global human tendinopathy market is estimated to be greater than 5 billion. And that's growing at 5% a year. So in 10 years' time, we could be over 10 million. And I bet I know exactly where that money's going to. It's not going to the treatments that we know are effective for tendinopathy, and that's exercise therapy. It's going to dubious and, as I said, potentially harmful interventions. And why is this? Why are we having issues? Well, I believe there's lots of parts of tendinopathy, certainly in the pathophysiology, that's an enigma. It's a complex pathophysiological process. If you look at the theories that underpin this pathophysiological process, you've got really two outstanding theories. One is the tendon response model, and that puts the tenocyte, that's the cell within the tendon, at the core of that process. And so we've probably heard of the tendon continuum model, degenerative versus reactive model. And that certainly explains some of the pathophysiology of tendinopathy, but it certainly doesn't explain all of it. And then we've got the inflammatory mediated model, and this is a very interesting model, and this has come to light over the last 5 to 10 years. And we know now that, in fact, there are chronic inflammatory cells that we think potentially could set up this process. And this is really the first paper that I'd advise those interested to read. Neil Miller, who is an orthopaedic surgeon in Glasgow, has done some fantastic work looking at inflammation and the mechanisms associated with this pathophysiology. And I strongly advise you to read his paper because it can open us up to potential targets for therapies. We're looking at particular targets, targeting the cytokines and interleukins. I think a very good paper. So pathophysiology really is not well understood. Pain is not really well understood. We don't know exactly where the pain is coming from in tendinopathy. So there's some very good studies, biopsy studies performed in northern Sweden over 10 years ago that found that in a pathological tendon you have lots of evidence of possible local nociceptive drives. You have abnormal tenocytes, you have abnormal receptors, and you have this ingrowth of blood vessels and nerves that could transmit pain perception. But we still don't know exactly what causes that nociceptive drive or that nociception. And interrelated to this, on top of this, you've got lots of central modulation. So the brain and the spinal cord are modulating that information coming from the tendon. And in fact, particularly with upper limb tendinopathy, rotator cuff, tennis elbow, you have evidence of central sensitization, similar to what you see in chronic low back pain and other chronic conditions such as osteoarthritis. So the brain and the spinal cord are upregulating that information coming from the tendon. And this is again interrelated to some new information that states that patients' beliefs are very, very important in how they perceive their tendinopathy and potentially could upregulate this drive from the tendon. So it's very, very complicated, and we don't really understand the mechanisms that underpin pain and tendon pain. We know that exercise therapy has level 1 evidence, but actually, do we know how exercise works in tendinopathy? Well, in fact, I don't think we do. I mean, it could work on the tendon itself, it could work on the muscle, it could work on the brain or the spinal cord. I think it works on all of the above. What about the studies? What do studies say about exercise and improving tendon pain, improving function? Well, Docking and Cook did some very good studies using high processing imaging. This is UTC imaging. And they found that painful tendons have more normal tendon, that's the green part of the tendon, than abnormal tendons. So painful tendons have greater green than tendons that are non-painful. But unfortunately with these studies, they're very good studies, but they're cross-sectional studies. So they're taken at one time frame, for we don't really have an understanding of what happens with exercise over a longitudinal study. So it doesn't really explain how exercise works in tendons. There's some fantastic studies done by the Danish group using radioactive carbon. They found that there's really little collagen turnover after the age of 13. So exercise probably doesn't increase turnover that much in tendons. In a follow-up study in 2018, they found that, in fact, in tendinopathy patients, you have an increase in turnover preceding the time of pain. So this is really confusing. Where that occurs and why it occurs is really unknown. So again, lots of unknowns in how exercise affects tendon pain and function. And there's an increased interest now in this area here, which is the interfascicular matrix. So collagen fibres are made into fascicles, and in between the fascicles is the IMF, or interfascicular matrix, and this seems to be the target and potentially maybe where exercise works in tendons, but we really don't have any idea or not sure of exactly where it affects the collagen fibres. How effective is exercise? So if you see a patient with Achilles tendinopathy and you place them on a rehab program, how effective is it? Well, again, look at the studies. So a study performed in 2014 found that 55% respond to rehab. A review paper in 2009 found that 29% fail with our rehab programs. So I think about 75% respond, and that leaves 1 in 4 of your patients that present to your clinics fail a rehab program. So the next question is, well, maybe they haven't been doing the right rehab loading program. What is the optimal program? Again, if you look at the studies and critique the studies, you find that there's no difference between these loading programs, so eccentric, heavy slow resistance and progressive. Certainly no difference in pain and function, but perhaps satisfaction might be improved in those loading programs, particularly the heavy slow resistance, where you have less you need to do less exercise. So the answer is we don't know. We don't know what's effective. There's lots of theories, but look at the studies and come to your conclusions. And I think if you come to your conclusions, you must say we don't really have an idea. And it makes sense that progressive loading is the optimal loading program. It makes sense in a rehab general principle perspective, but really we haven't tested progressive loading against other forms of loading programs. This is a fascinating study. So this is a longitudinal systematic review looking at rate of improvement of pain and function in patients who present with tendinopathy. So I met this senior physio, Miles Murphy, last week at the Tendon Symposium, and it's a very eloquent and intricate study because it looks at how exercise improves function, but not just whether it does or not, but also at the rate of change. So I think this is the second paper that you should read on exercise and tendinopathy. And what we find here, we find a number of things. We find that improvements occur almost immediately. We find that the minimal detectable change occurs at 4 weeks. That is a Visa score of greater than 10. So it takes 4 weeks before patients realise that they're improving at a minimal clinically detectable change. And more importantly, the improvements are not linear. So there's 3 peaks. There's a peak initially, a peak at 4 weeks, and then a peak at 12 weeks. And at 3 months, there's a maximum effect. So any time after 3 months, the rate of improvement drops. So if you don't get an improvement within 3 months with exercise therapy, it's probably unlikely you're going to get an improvement, and you need to look at other possibilities or other adjuncts. So this is a great paper for setting patient expectations. So it's a really good paper for me to explain to patients, you need to do a loading program, it's going to take 3 months, you should see an improvement almost immediately, but it's not going to be linear, and there'll be ups and downs in the rehab program. But at 3 months, if you're not getting improvement, then you need to look at other possibilities. So what are they in tendinopathy? And we heard a little bit about injections and other interventions in the previous lecture. So this is what doctors and physios can do to you. You can have shockwave therapy. We can inject the tendon with cortisone, PRP, stem cells, or we can operate on tendons. So what's the evidence for these adjuncts? Well, in fact, probably the best out of that bunch is shockwave therapy. This is a systematic review published in the British Journal of Sports Medicine in 2017 that found that, in fact, for lower limb tendinopathies, there's moderate evidence for some tendons, particularly hamstring origin tendinopathy, lower evidence for Achilles and glute med tendinopathy, and probably no evidence for patellar tendinopathy. The beauty of shockwave therapy, as you know, is it's non-invasive. And so you're not subjecting the patient usually to potentially harmful interventions. What about injections? So this was a fantastic study, and I've got a conflict of interest here because I was co-author of the study. But nevertheless, it was actually written by a good colleague of mine, Dr. John Orchard, and it's a narrative review of the evidence base for ultrasound-guided injections for tendinopathy. And I think anyone who does injections should read this paper because it is a good base for your evidence base of tendons and tendon injections from about 2 months ago. And what are the conclusions to the narrative review? Well, we find that cortisone has short-term efficacy, but really you're subjecting the patient to potentially long-term or medium-term and long-term harm. So we really should stop using cortisone for a lot of our tendons, or at least limit the use of cortisone for potential cases that are intractable. There is evolving evidence for PRP, particularly in plantar fascia and tennis elbow. However, if you look at these studies, and again critique the studies, PRP seems to be compared to cortisone. And we know that cortisone has medium long-term harm, so PRP is always going to look better when you compare it to a substance that causes harm. So if you take a photo with the ugliest boy or girl in the class, you're always going to look better. And so PRP seems to look better in these studies, but in fact it might be an effect of just having cortisone, being compared to cortisone. What about high volume injection? Well, again, look at the studies. If you look at the studies, and these are high evidence studies, so this is a study comparing high volume injection, which is blue, to PRP and sham, so RCT level 1. Good short-term effects, but it tends to even out at 6 months. So not so good in the long term. And this study that was actually presented last week at the Tendon Symposium looked at high volume injection with cortisone versus high volume injection without cortisone. And in fact, you get the same effect. So you get an improvement at 6 weeks, and then at 6 months, it equals out. So the question there that I have is this just a cortisone injection? So you're just doing a cortisone injection to get the positive effect. Why do you need to do a high volume injection to get this effect? So lots of questions about high volume injections. So we need to use less cortisone, there's no doubt about that. I've got a plethora of studies. I work with a surgeon who sees end-stage tendons. And this is a good example of an elite track and field runner who was subjected to a high-volume injection with cortisone, and you can see the track mark. So this is an inadvertent injection of the tendon with cortisone. Cortisone is necrotic, and it'll cause necrosis of the tendon, and you'll get this sort of picture. Another case of an amateur runner who had a high-volume injection and a partial tear, and he had crystals within his cortisone injection. And this poor lady who had a cortisone injection for Achilles tendinopathy, and she sustained a significant partial tear of the tendon and necrosis and had to have it excised. I always hear people say there's no evidence for cortisone and detrimental effects on tendons. Again, I'd implore you to look at the studies. This is a study by an orthopaedic surgeon, Ben Dean, who found unequivocally that cortisone has negative effects on tenocytes as well as mechanical properties in the short term. So you put the anecdotal effects with the very good in vitro effects. My conclusion is we need to use less cortisone and certainly be very judicious in the use of cortisone. What about surgery? Well, in fact, there's little evidence for intratendinous surgery. This is a study in 2006 comparing eccentric training with surgery and finding that, in fact, it's a 50-50 proposition. Heads you win, tails you lose. And if you lose with surgery, you lose pretty badly. So you need to be cautious about people entering surgery. I work with a surgeon that does a tendon debridement procedure. So we're targeting the areas of increased blood flow where the perineural ingrowth occurs. But surgery is surgery. We need to be very careful about subjecting people to even this type of minimally invasive surgery. So I've just said that tendinopathy is an epidemic. It's an enigma from a pathophysiological perspective and pain perspective. Exercise works, but we don't know how it works. Our adjuncts are not very good. Cortisone can make you worse. Where to from here? Where do we go from here? Well, in fact, there is the light at the end of the tunnel. And I'm going to talk about two emerging concepts. One, predominantly in rehabilitation and how we optimise the rehab program to improve our patients. And I'm then talk about some of the therapeutics or the niche therapeutics that practitioners are using, other than what we've got at the moment, which is not particularly good, to try and improve our patients with this difficult and complex pathophysiological process. So what about rehabilitation? How can we optimise rehabilitation to improve our outcomes? I said 75% of patients improve, but 25% don't improve. So these are my principles for rehab. It has to be multidisciplinary. So I think the 20 or 25-minute consultation that an SEM doctor can do is not enough for these patients. So I work with a physiotherapist, Chris Myers, who's a specialist physiotherapist here at ISCH. We do a tendinopathy clinic. I also work with a surgeon at Pure Sports Medicine. And we give our patients 1 hour, do a full history examination. We do investigations, ultrasound, shear wave elastography, sometimes UTC, and we look at these adjuncts. And then we look at potentially measuring outcomes as well. These patients need time. And they also need time to correct this, which is their beliefs of their tendon pain. Beliefs of rupture, beliefs that by exercising they'll actually do more harm than good. So these patients have usually done a rehab program, but we're trying to optimise their loading. So how do you optimise loading? Well, I think if you want to load patients, you need to load heavy. And I think that means getting patients into the gym and getting them active and getting them pushing significant weight. I think a home exercise program, if you talk to the therapists that I work with, they really struggle to get patients loaded up if they're doing home exercise programs. So what is optimal loading or optimal tendon adaptation? I mentioned that we really don't know, but this is a fascinating systematic review, and this is number 4 of my paper. This is looking at human tendon adaptation to response to mechanical loading. So it's looking at the response of the tendon to heavy loads. And this is by the group BASEM and Aramapatsis, who are well known in the tendon field. So certainly if you want to get change in the tendon, you need to push heavy. So we're looking at 70% of your maximal voluntary contraction. But the type of load isn't important. So whether you do eccentric, isometric or concentric, it doesn't really seem to matter to the tendon. And what they find is that in fact you get an increase in the stiffness of the tendon, and potentially that could be a mechanism of how pathological tendons improve. And you need more effective longer durations to achieve that effect. If you look at isometrics, and this is very debatable, there have been some practitioners that have proposed that isometrics improve tendon pain, but there are other studies that show the reverse. In fact, it doesn't improve tendon pain. So isometrics, in my opinion, are only used if you get an effect of tendon pain. So certainly there's conflicting results with isometrics. So you need to load heavy. What I find with patients as well is that giving them strength goals is very effective. So rather than saying get to the gym and lift weight, I'm saying you need to lift your body weight, or you need to at least push 1.3 times your body weight when you're doing a single leg press. So people are very goal orientated, and I tell them to try and reach these strength goals before they consider adjuncts to therapy, such as shockwave or injection therapy. So certainly in the clinics that I work in, it's a very effective tool of getting people stimulated and exercising, so giving them strength goals. And interrelated to this is also strength testing. So we're trialling isokinetic testing for patients that have Achilles tendinopathy and patella tendinopathy. And many of you are aware of isokinetic testing and how it dynamically loads the muscle at every range of motion point. And so it seems to be more effective, or potentially could be more effective in patients with strength training. And we tend to use isometrics, or certainly the physios I work with use isometrics for objective data, so looking at strength and endurance and looking at ratios, and also training. So you're actually training patients or doing a loading program so you can load very heavy without getting pain, and looking at being very specific to the particular tendon that you're targeting. So there's lots of advantages for doing isometric loading, or isokinetic loading, sorry, in these patients. But it's not all about strength. So the target now is away from achieving strength goals, and certainly that's what we need to do. But the target now is about the central nervous system. There's some evolving evidence that with chronic patella tendinopathy, you tend to get altered motor cortex patterning, which then produces muscle inhibition, and perhaps using a metronome can actually reverse that motor cortex patterning. And certainly there are other practitioners, Seth O'Neill and Peter Maliaris, that are looking at trying to improve motor control or muscle control as a way of optimising rehabilitation programs. So they're the things that we're moving to. We're moving towards not only improvements in strength, but also improvements in controlling that strength. And certainly research is moving towards trying to find the optimal program to achieve both goals. What about therapeutics? And I call this the nasty stuff that doctors can do. What about therapeutics? What's new in the therapeutic realm, apart from PRP and stem cells, and I've heard just today tenocyte implantations? I mean, surgery really is reserved for failed rehab. I mentioned that. And I work with a surgeon who does a tendon debridement procedure. I mentioned that before, where he looks at the vessels and targets the vessels. We've done a very interesting, this is a case series, so lower level evidence showing an improvement in visa-P and also an improvement in structure after 6 months of this procedure. But as I mentioned, this is surgery and it involves risks, and these risks are risks of infection and potentially risks of ineffective outcomes. So now people are moving towards percutaneous procedures. So this is very interesting. This is an example of a trigger finger. So these are done very regularly in the United States. So you're using a needle to actually debride the A1 pulley. The results are pretty spectacular in very good hands, of course. And so this is now moving on to tendon and potentially using this theory of neovascularization and increased neural ingrowth to target that area using instruments or bespoke instruments to reduce that local nociception within the tendon. So you're trying to debride the neural infiltration and reset the tendon. So this is a case report and from Medrick Hall, who's a sports physician in Iowa City, and he's using tendon debridement as an in-season method for treating his patellar tendons. So he doesn't worry about shockwave, he doesn't worry about PRP, stem cells and so forth, but actually does a tendon debridement procedure under local anaesthetic and is doing a case series and getting very good results. So this is the direction that we're moving to for the therapeutics for those cases that fail to respond to loading programs. The other area that I think is really exciting is these therapeutic agents. So I mentioned that Neil Miller is doing some fantastic work with inflammation and finding lots and lots of targets. So there's this complex interrelationship between chronic inflammatory cells and tenocytes, and there's production of interleukins and cytokines, and these are all the targets that he's looking at to try and circumvent the process of tendinopathy and improve pain. Versus this, which is PRP, which is really non-specific. We're just injecting growth factors into a tendon. We've got no idea what they do. We've got no idea how they work, versus a targeted approach. So I think this is a very exciting area of tendon research development. And I'm going to predict now that in 10 years' time, rather than treating patients with shockwave or injection therapy, we're going to give them a therapeutic product, something that blocks one of these agents, and then get them set on a rehab program. And certainly it is happening. The target now is interleukin 17A, which is thought to be a very important interleukin in the early stages of tendon disease and tendinopathy. And there is a phase 1 randomised controlled trial, which is placebo-controlled and double-blinded, happening in Glasgow at the moment. So we're moving the way of inflammatory arthropathy. Where inflammatory arthropathy was 20 years ago, we had non-steroidals and cortisone. Now we have lots of biological agents. I predict that tendinopathy in 10 years' time will have agents like this that will inject into patients, and then they'll be set on a rehab program to progress their return to sport. So in summary, tendinopathy remains an enigma. It's an epidemic. We don't really understand it. Pathophysiology is not really well understood. How exercise works remains elusive. We need to be very careful of adjuncts, particularly careful of cortisone injections, and also careful of other injections like PRP and stem cells until there's more evidence. There's some emerging concepts. I mentioned the emerging concepts in rehabilitation. So certainly looking at multidisciplinary clinics, looking at strength goals and trying to improve motor control and using strength testing. And then some of these niche procedures, percutaneous procedures, but more exciting, the molecular age of tendinopathy has arrived. Thank you.